Hello, good afternoon, everyone. I hope you can all hear me. My name is Ian Hovis. I'm one of the new cardiologists at Children's. I primarily do inpatient and ambulatory care general cardiology, work out of a lot of different clinics, but today I'm working out of the Rockville office. So today's lecture is entitled Family Matters, When to Refer for a Cardiovascular Family History. And really this stems from my interest in when to refer to me from a primary care provider to a general cardiologist. And as a resident in my general cardiology, I was at Children's Hospital in Montefiore in the Bronx. I really didn't have a clear education or any textbooks that clearly showed me exactly how do you take a comprehensive family history. And it was really through fellowship and now with my young attendingship in which I was able to gain experience and through talking with other individuals and really establish my style of taking a family history. And so in preparation for this talk, I was able to look through a lot of the main textbooks that we use, and even in our ambulatory care outpatient cardiology chapters, the section on family history is just a very small paragraph. So I thought that that was even more important to talk today about when I feel it's important to refer for cardiology. And so the outline for the talk today is we will be looking first at just an approach to how to take a cardiovascular family history, and then also the practical applications of that information. So what questions are we asking and why are we asking them, and what disease processes exactly are we trying to diagnose and trying to help stratify for that specific patient or that family. So I will look, I think, through 7 different points that I take for one of my comprehensive family histories and specific diseases within that. Then I'll be talking about 3 specific genetically inherited disease processes that I often see in my outpatient setting in kind of epidemiology, the genetic basis, the pathophysiology for those 3 processes, and then we'll finally wrap up with some questions. So I think the family history is going to start having a greater and greater impact on our histories, both as subspecialists as well as general practitioners, for the main reason that I think genetics is going to continue to play a larger and larger role in the care we provide for our patients. And so throughout time prior to all the genetic testing that is now available today, really a detailed family history was the first genetic screen that we had to really help stratify at-risk patients and families. And I think even today, specifically with genetics costing so much money and there's a lot of concern from insurance companies, I think that taking a comprehensive family history both to help the patient but also the family is very, very important. And so genetics, not only are we figuring out more disease processes through pathologic mutations, but we're also figuring out the inheritance patterns and exactly who we have to screen and why. And so the family history, I truly believe, has a significant impact on the management of our patients as we continue to butt into this genetic era that is obviously continuing to boom. It's specifically from a cardiovascular standpoint. Within the last 10 to 20 years, the number of pathologic mutations that have been identified has risen exponentially. And so I'll talk about that a little bit later in the talk about how we and I specifically utilize genetics and genetic testing in the care of our patients. So just a little bit of background. You can't have a cardiology talk without the classic incidence of congenital heart disease. So just to refresh for everyone, so it's classically cited as about 8 per 1,000 live births, or thought of as basically about 1% of all individuals will have congenital heart disease. This is likely an underestimate because this is really about live births. The true prevalence or incidence is probably closer to about 5%, but that's also taking into account stillbirths as well. And interestingly, which isn't talked about that much, is one of the things I'll be speaking about later today, and something that you guys all probably see quite a bit in your practices about bicuspid aortic valve. So bicuspid aortic valve is the most common form of congenital heart disease, and actually typically is not included in this 8 per 1,000 live births. And so the incidence of bicuspid aortic valve is thought to be about 2 to 5% of the population. And again, I'll speak about that a little bit later about in people who have a family member with bicuspid aortic valve, what is their at-risk percentage, and also what should we do with them. And so congenital heart disease is thought to be caused by a multifactorial etiology. And so only about 20% of all children with congenital heart disease will have, at this time, an identifiable genetic mutation that is disease-causing as the main contributor for the disease. 80% are unknown, but this is likely to change in the future as genetics becomes better and we're able to learn more and more of disease-causing mutations. But again, there's always that multifactorial component, and in that, environmental causes play a significant role. And so this is something that's interesting to talk about, especially for the newborn visit, is was there any maternal concerns while pregnant? And so things that can cause congenital heart disease are certain medications, such as retinoic acid or Accutane, valproic acid, just to name two. Alcohol can cause congenital heart disease, as does smoking. Certain toxins, radiation, and specifically infections, such as rubella, are known to cause congenital heart disease. Rubella can cause peripheral pulmonic stenosis and can also cause PDAs. So in looking specifically at genetics, about 20% are thought to be inherited on a familial basis, and the remainder, 80%, are thought to be a sporadic or spontaneous mutation. And with the genetics, outside of the familial cases, about 25 to 40% are from some identifiable syndrome. So 60% of children will have a sporadic mutation that is not associated with a syndrome. But again, I feel that as genetics continues to boom and we gain a lot more information, I feel like this probably will shift a little bit, and we'll be able to say either there'll be more of a familial component that had been not identified previously, or these sporadic mutations will find the disease-causing mutation rather than just call them unknown at this time. And so returning back to our family history topic, there are certain lesions within congenital heart disease that actually have a much stronger familial component than others. And I'll mention this later in the talk, but just to start off, really people with left-sided familial heart disease are the ones most at risk for a potential familially inherited component. And so for examples of that would be hypoplastic left heart syndrome, and also would be bicuspid aortic valve. And because of this great increase in incidence within these families, we do recommend screening of all first-degree family members by at least an echocardiogram with someone who we know has left-sided congenital heart disease. And there, we think of it between 10 to 20% increased risk of having congenital heart disease if you have a left-sided obstructive lesion. Excuse me. And so kind of getting back to my initial, when I was in residency and not really knowing what questions do I ask and then why am I asking these questions, I think it really comes because we don't really have clear recommendations about exactly what questions should we be asking our families in a general practice to help us stratify their risk of having some sort of cardiovascular malformation. In the setting of athletic participation, the AAP and ACC have done a nice job in having a pretty comprehensive both physical exam, personal history, and family history guideline of people at risk for sudden death, but not really as clear for people at risk for other forms of cardiovascular malformations. And so because of this lack of clarity, both from textbooks but also from our current recommendations, it does make assessing the risk of specific patients pretty challenging for a general practitioner. And so just briefly to talk about sudden cardiac death screening in athletes, because I know this is a major point for general practitioners, and I do see a lot of patients who are trying to join pretty competitive soccer or basketball leagues who do have a red flag on their screening test for sports participation. And so the reason why we are so keen on obtaining a pretty rigorous history and exam on these kids is because at-risk individuals have been shown, obviously, to have an increased risk of death during sports activities. And so to try to temper this risk, the ACC and AHA have released, and it's been updated, I think in 2004, a 14-element guideline about how to evaluate these healthy individuals, really from an age 12 to 21 for us, both looking for congenital and also genetic heart diseases. So within this 14-element checklist, there are 7 elements of personal history, 3 elements of family history, and 4 elements within the physical exam. I'm just going to focus on the family history today, but this is easily accessible online if you don't have this in your records. And so the recommended 3-point family history specifically for screening for sudden death in children at the athletic screening visit is, number 1, asking if there's any family member with a premature death, which is classified as sudden or unexpected before the age of 50 that was attributable to heart disease. I oftentimes will get people who say that someone died from a brain issue or some other form of cancer or something like that. So instead of just asking for sudden death, it is often important to ask if the family knows the etiology or any more information about the cause of that death. But certainly if there is someone with a premature death attributable to heart disease, that would be a potential risk factor for that child. The next thing is also kind of on the same note, is that if someone has a disability from heart disease in someone less than 50 years of age. And really what this is getting to is if you have an aborted sudden death but then have some comorbidity from that, for example, if you had a stroke or something from ischemic heart disease, wouldn't necessarily have premature death, but you obviously would have had a morbidity from some premature cardiovascular disease. And then the last thing, and I'm going to spend most of my time on this next point, is asking briefly about if someone has had cardiomyopathy, specifically hypertrophic cardiomyopathy or dilated cardiomyopathy, if the family knows of anyone with long QT syndrome or any ion channelopathies or arrhythmias, and then someone who potentially has Marfan syndrome or another connective tissue disorder, which can predispose you to a thoracic aortic aneurysm or dissection. And I'll get into that in more specifics later in the talk. And so what we're really trying to prevent is hypertrophic cardiomyopathy, because this is the most common cause of sudden death in young athletes, which accounts for nearly 1/3 of all cases of sudden death within athletes. And so outside of sudden cardiac death, there obviously is a lot of other things that we're trying to screen for, mostly for the stratification to prevent morbidity in patients. And so this is what I'll be focusing on next, but really it's trying to get to different types of cardiomyopathies, different types of arrhythmias that can cause cardiovascular disease, but don't necessarily have an association with sudden cardiac death. And so this is the 7-point family history that I typically take, and I'm going to break these down one by one and basically talk a little bit about each point and then also line out exactly what diseases we're trying to assess for. And so I always ask if there's any first-degree or second-degree relatives that have congenital heart disease. Is there anyone that the family knows has syncope or has had seizures in the past? Anyone with known arrhythmias or having a pacemaker or defibrillator placed? The age of that placement is obviously quite important. Have there been any family members with deafness or anyone born deaf? I really try to differentiate this from someone who has developed deafness later in their life, so it's very important when asking to make sure that is either they were known or born deaf or this occurred early in their childhood, and I'll get into why that's an important question. On a cardiovascular family history, because I'm not sure if everyone is aware that deafness has a role in kind of the conduction system. Also, because we spoke about before, but a myocardial infarction, less than 50 years of age, and then also anyone in the family who has had unexplained sudden death or a death of an infant. And so to kind of take that piece by piece, so the first point is any family history of congenital heart disease. And interestingly, the risk for the individual child at the visit, it varies based on who in the family was diagnosed with congenital heart disease. And so if the mother of that child was diagnosed with congenital heart disease compared to the parent, there is an increased risk. The risk is thought to be about 5% if the mother has congenital heart disease and about 3% increased risk if the father does. Moreover, if the parent has congenital heart disease, there's an increased risk than when compared to if the sibling has congenital heart disease. This doesn't necessarily play into the determination if they should be referred to cardiology, but it's an interesting point is that whoever has the congenital heart disease really determines potentially the risk of that child having congenital heart disease. And as I spoke about earlier in the talk, really the highest familial inheritable risk for congenital heart disease has to do with a specific type of congenital heart disease. And so it's thought that no matter what, if a family member has congenital heart disease, the child that you're seeing is going to be at an increased risk compared to another member of society that does not have a family history of congenital heart disease. And that risk is somewhere between 2 and 20%, and that 20% really is for individuals with a family history of hypoplastic left heart syndrome. That is as high as a 20% recurrence risk, which is very alarming. And so if anyone does have a family or a patient that has either a family member or someone with hypoplastic left heart syndrome, it is wise and recommended to have every first-degree relative screen for congenital heart disease. And something I do want to spend a little bit of time on is bicuspid aortic valve, because this has up to 10% recurrence risk factor. And so bicuspid aortic valve is an interesting thing because not a lot of adults I've found actually necessarily know their diagnosis. Certainly some people, specifically those with more severe disease, know that they have bicuspid aortic valve because either they're on medications, they follow closely with a cardiologist, or they've even had surgery on their aortic root or aortic valve. However, there's quite a few individuals who don't know what exactly they have, but they're able to tell you that they do have some form of aortic valve disease. And so almost certainly it probably would be aortic valve disease. Really the only other thing would be a more severe form of congenital aortic valve disease, like a unicuspid aortic valve, but they would clearly know that, or if they actually had rheumatic heart disease, which is typically thought of affecting the mitral valve, but can have isolated aortic valve disease. So because of this uncertainty, as long as the child is otherwise doing fine and is asymptomatic, if the family member is able to either contact their physician and figure out exactly what is wrong with their aortic valve, I feel like we do have some time before just quickly referring to cardiology given a potential aortic valve disease. Certainly if they have or the parent or sibling has bicuspid aortic valve, you should refer. But if they don't and the child is asymptomatic, I do feel like taking some time to see if the family member can get back to you guys with the true diagnosis might, in fact, help limit the amount of referrals or the burden for the family to come see me if there's not a true inheritable risk of whatever disease they might have. So I always try to, specifically with aortic or left-sided valve disease, get as much information as I can. The next thing we're going to focus on is syncope and seizures. And so I always ask any first or second degree relative that faints often, faints unexpectedly, or has seizures that really haven't been clearly diagnosed. Obviously, any kind of syncopal episode can have convulsions, which can be confused as seizures. And if the person that the family member is speaking about has not been formally diagnosed with epilepsy, oftentimes this, or sometimes this can actually be secondary to a heart issue or secondary to syncope. Moreover, if we have the time, getting a little bit more information if the parents know about the type of syncope is very important. For example, if it's like a simple vasovagal syncope in which the family member has a prodrome or faints while seeing blood or being frightened, that is most likely not an inheritable form of syncope or something that necessarily needs to be referred from a family history. But if the family member comments that the individual just faints randomly or faints during exercise, that obviously is quite concerning. And what we're trying to screen for there is, number one, is pulmonary hypertension. This is not necessarily something that is common at all, and a lot of family members probably don't even know what it means, but it can manifest quite commonly as just random syncopal events. And so this can either be at rest or it can be at minimal exertion, like walking around, and someone will not have a prodrome and just drop. And so lack of prodrome, to me, is very concerning, either just from a normal personal history or family history, and potentially could suggest pulmonary hypertension. Something else it can suggest is different forms of arrhythmia. Typically, you would anticipate to have the feeling of palpitations before having an arrhythmia. Sometimes you don't necessarily have that if it goes into a very abrupt arrhythmia, but typically the family member, when screening for a syncope, would also potentially have a positivity for arrhythmia. These arrhythmias, and I will speak about this a lot more, would be long QT syndrome and Brugada syndrome and a few others, which I'll get into in a little bit. And then secondly, undiagnosed congenital heart disease can also cause what would appear to be a syncopal event. These can include an anomalous origin of the coronary artery, and so there's both, you can get an anomalous left or an anomalous right, and this will happen typically during exercise, and the reason for this syncope or sudden death is that you're not supplying enough demand as the demand increases during exercise, and then you'll have a myocardial infarction and can pass out and pass away. In talking about this, in stratifying the left versus the right, a left anomalous coronary artery is a more concerning diagnosis and is typically recommended for surgery versus the right anomalous coronary artery gets a little bit more confusing about the recommendations, either surgery or actually sports, withdrawal from sports. Other types of family histories that can cause syncope would be cardiomyopathies that could potentially be undiagnosed, or as I've mentioned a couple times today already, left ventricular outflow tract obstructive lesions like bicuspid aortic valve with severe aortic stenosis. The next piece of family history I always ask about is if there's any family history of known arrhythmia or any members of the family that have had a pacemaker or defibrillator. Again, the age at which these occur is very important because as individuals get older, especially in this country in which we have a very high burden of cardiovascular disease and early coronary artery disease, a lot of these can be secondary to ischemic heart disease and not due to heritable heart disease. And so again, I think 50 is a good measure in that if the arrhythmia or the pacemaker or defibrillator were started after 50 years of age, it is less likely to be caused by a heritable etiology versus a etiology from ischemia. So the 5 things that we're really trying to evaluate for in asking a family history of arrhythmia is, number 1, long QT syndrome. And long QT syndrome, which I'll spend some more time on a little bit later, is the most common inherited form of arrhythmia. And so if someone does have arrhythmia or even knows they have long QT syndrome, I'll explain later about exactly what I think the workup should be and when they should be referred to cardiology. The next thing we're trying to evaluate for is Brugada syndrome. And this is actually what you see on your right is a Brugada pattern that we'll see in lead V1, V2, and it's called a scalloped T wave. And this typically can be involved with sudden death. Interestingly, usually occurs during sleep, and sometimes you can enter arrhythmias during times of fever. So when assessing arrhythmia, it's also important to assess for sudden death and the conditions around that sudden death, because it can help us target our diagnoses based on when it happened and how it happened. Long QT syndrome can also have sudden death. It can happen during sleep. It can also happen during exercise or swimming as well. The next thing we're looking for is something called CPVT, or catecholaminergic polymorphic ventricular tachycardia, which is a mouthful. And it's a pretty interesting disease. It is inheritable, and this is an ECG of someone with CPVT. And so what it basically means is that when you have a catechol surge, like you have a stressor, you get excited, you can actually go into ventricular tachycardia. And so the way that this would manifest is that every time someone gets really, really excited, they can either have palpitations or even faint from poor cardiac output. And so it is something to screen for in terms of arrhythmia. Typically, if someone has CPVT, they will know it because it is quite rare, but it is one of the things that we're looking for when we ask about a family history of arrhythmia. The next is much less common. It's called arrhythmogenic right ventricular cardiomyopathy, or ARVC. And what this is it's a form of cardiomyopathy that's also associated with ventricular tachycardia, and it's when the right ventricle myocardium is actually taken over by adipocytes and fibroblasts, and it leads to a very dilated, dysfunctional right ventricle, but has a high risk for ventricular tachycardia and ventricular arrhythmias. Most of these have been ventricular arrhythmias. There is a rare cases of atrial arrhythmias that are heritable. Very, very, very rare cases of Wolff-Parkinson-White can be inherited, but most do not. And so in family members who have had SVT and family members who have had ablations, and it's just one family member, it typically is not a concern for a heritable cause or of heart disease. However, if someone comes in and says that 4 different people within their family have SVT or 4 people have WPW, certainly those could be one of those rare instances of heritable Wolff-Parkinson-White. But again, typically people with isolated SVT, isolated PVCs or PACs, that is not a reason to refer to cardiology, as it's unlikely to be inherited. So getting to deafness, so something I've learned in fellowship, the importance of asking, and it's really to exclude a form of long QT syndrome called Dravel-Imling-Nielsen syndrome. And this is associated with profound bilateral sensory neural hearing loss. And this is, if someone does say that they have a family member with a child who was deaf, or someone who was diagnosed with deafness at a young age, taking a little bit more time to ask the etiology of that deafness if the family member knows. Because if it is sensory neural and bilateral, it's still a rare possibility, but something that I do see quite often, referrals mainly from genetics to exclude for Dravel-Imling-Nielsen in individuals with sensory neural hearing loss. The reason why it's sensory neural hearing loss is because the cells in the ear utilize the same receptors that are part of the long QT syndrome, the sodium and the potassium receptors. This is not associated with conductive hearing loss, however, as there's really no relationship with the sodium or the potassium channels or the conduction system with conductive hearing loss. So if it's pretty clear that it's conductive, then there's not a necessary reason to refer to genetics or to cardiology. However, if it's sensory neural based on the audiogram, then certainly especially if it's bilateral, a referral to genetics and or cardiology would be valid at that time. Now getting to early myocardial infarction. So really the AAP and ACC define early myocardial infarction as a female before 55 and a male before 65. However, we tend to, in the ACC, it tends to recommend screening for less than 50 to try to increase the sensitivity of the screening test. And so in people with early myocardial infarctions, this is suggestive of having early coronary artery disease, which is obviously an independent risk factor for early cardiovascular disease. And so in individuals who have a family member, a family history, specifically a first-degree relative of someone with early cardiovascular disease, the AAP recommends doing a fasting lipid profile in children between 2 and 8 years of age. So in this setting, with a sole positive family history of someone with an early myocardial infarction, you don't necessarily have to refer right away. What I would recommend is to obtain a fasting lipid profile or just a lipid profile, and if there are concerns there while following the guidelines, then that would be good grounds for referral to cardiology. But just a family member with an early myocardial infarction without having a fasting lipid profile, it isn't necessary for a referral based on that family history. And lastly, on my history is I ask about unexplained sudden death or death of an infant. And I kind of alluded to this earlier, but it's really important kind of the circumstance of that sudden death. For example, did the death happen during sleep, which could be consistent with Brugada syndrome or long QT syndrome? Did it happen during swimming, which actually could be consistent with long QT syndrome? Or did it happen during exercise, which can be potentially consistent with CPVT, catecholaminergic polymorphic ventricular tachycardia, or from an anatomic issue or abnormality such as anomalous coronary arteries or left ventricular outflow tract obstruction. It could also be associated with pulmonary hypertension as well. And something that's very important, and it's not always talked about, but was an autopsy performed on that individual. And how that really will help is basically for etiology of the unexplained sudden death or that death of the infant. Because if they do find congenital heart disease, then that will, specifically of the left side, that would prompt a referral based on that family history. But also, now that genetics are getting better, they're actually starting to do genetic testing, especially on young infants with sudden death, to mainly look for potential arrhythmia as an etiology. And so if that comes back positive, specifically for a long QT syndrome, then that would be suggestive to have the rest of the first-degree relatives screened. So if the family knows, or you can ask about autopsy, that is oftentimes very, very helpful. And similar to a bicuspid aortic valve, again, if the child is doing very well and the family member does have concern for someone with unexplained sudden death, it's often helpful to try to first get the autopsy report or get the genetic testing prior to just referring to cardiology, because if it was just a myocardial infarction, that wouldn't be necessarily a time to refer to cardiology, but rather a time to be more diligent on looking at the lipids of that child. And so now I'm going to go over three of the probably most commonest inheritable forms of heart disease that I see, and kind of look at the epidemiology, the genetics, and also how I screen for these individuals. And so what we're all trying to prevent is sudden death, specifically death of athletes, because we all see in the newspapers, high school students who drop on the basketball court. And again, this most commonly is from hypertrophic cardiomyopathy. And so the quoted incidence of this is quite low. It's only about 0.47 per 100,000 children, but it is the cause of about 1/3 of all forms of sudden death in athletes, and is therefore the most common cause of sudden cardiac death in athletes. It can be caused either by primary, which would be a mutation, a point mutation, typically in the sarcomeric proteins, but can also be from secondary causes, which is associated with some type of syndrome. So 3 of those syndromes that we see are Friedreich's ataxia, Pompe disease, and Noonan syndrome are all associated with hypertrophic cardiomyopathy. So the secondary causes are not from the same etiology as the primary cause, which is what we're trying to screen for from the family history. They're from different reasons. And so part of the reason why it's so catastrophic and so concerning is that it is inherited in an autosomal dominant fashion. As I mentioned earlier, it is a mutation in the sarcomeric proteins. And so then the question is, well, how good is genetics and when should we refer to genetics? And so there's a big spectrum of the utility of genetics, especially within the cardiovascular subspecialty. But hypertrophic cardiomyopathy actually has one of the best yields for genetic testing if the disease process is thought to be familial. And that's about 40 to 70%. So that means that if someone has HCM and we refer for genetics, there's this 40 to 70% chance of getting a positive gene mutation. And that really helps, not necessarily for stratification of that individual. They already have the phenotype, and that's why they're being tested. But it helps with the stratification of the family members. Because what can happen is you can be phenotype negative but genotype positive, and the question is, what do we do? Because if we don't have positive genetic testing, we assume everyone will be genotype positive and phenotype negative. And so we will be unable to tell the family members if they are at risk of developing HCM at some point. And so within pediatrics, hypertrophic cardiomyopathy typically starts to evolve around adolescence. And so how we screen for these children is every 3 years, but when they reach adolescence, we screen every year. And then when they get out of adolescence after 18, then we go back to screening every 3 years as long as they are phenotype negative. And so if the sibling or if the family member in the has the point mutation and has a genotype positive, what we can do is screen all the family members within the first degree relatives for that specific mutation. And if they're negative, then they will likely not have the phenotype of hypertrophic cardiomyopathy, and therefore they will not have the stress of worrying about potentially developing it at some point or have to come and see cardiology every year. So this is one of those cases in which we always send genetic testing to help basically stratify the rest of the family members. The next is long QT syndrome. And as I mentioned earlier, this is the most common inherited arrhythmia with an estimated prevalence of 1 in 3,000 children. And so why long QT syndrome is concerning is that it can cause ventricular arrhythmias, specifically torsades de pointe, and it can cause syncope. And it's an abnormality in the repolarization of the heart, and it takes longer to repolarize. And so the concern is if you're repolarizing, which is the T wave, and you have a PVC come in right at the T wave, you'll have an R on T phenomena, which can put you into torsades de pointe, and that can often be life-threatening. So again, similar to hypertrophic cardiomyopathy, this is also inherited on an autosomal dominant basis, and that's why it's something that we are very aggressive about trying to diagnose. There are numerous mutations that have been associated with long QT syndrome, and most of them encode for the potassium and the sodium ion channels. Interestingly, Brugada is also a mutation in one of the sodium or potassium channels, but one is a loss of function and one is a gain of function. So there can be the same mutation, but it just depends on, is the protein going to be made in excess, or is the protein not going to be made enough of? And that will determine the diagnosis that the child will have. This is the best yield of genetic testing of any diagnosis in pediatric cardiology, and it's quoted at about 70%. So we do have an arrhythmia panel that we send if there's concern for long QT. And again, if someone is positive with genotype, that helps stratify the rest of the family members. And so if genetic testing has not been pursued, or even if genetic testing is negative, but the child still has the phenotype of long QT, we will recommend to screen all first-degree relatives with at least an EKG. The reason for this is that we obviously don't know all of the mutations that can cause long QT syndrome, and we assume that they're all going to be, or most of them will be in autosomal dominant fashion, which is why we will recommend screening all the first-degree relatives. Interesting, Travell and Legg-Nielsen syndrome, which I mentioned earlier about sensory neural hearing loss, is actually an autosomal recessive inheritance pattern. And because of the importance of genetics, the proband, or the person first diagnosed with the long QT syndrome, should be referred to genetics. And if they have a positive mutation, then we will also do point mutations on the rest of the family members. The third specific diagnosis I'm going to focus on today is the thoracic aortic aneurysm and/or dissection. And so this has been associated with mostly with connective tissue disorders such as Marfan syndrome, Loeys-Dietz syndrome, or Ehlers-Danlos type 4. However, it is continuing to get an increasing interest about different genetic causes that can cause a thoracic aortic aneurysm or dissection, as this can cause sudden death. And so the genetics of this, again, a theme here, this is autosomal dominant, and so it is important to screen for these things in first-degree relatives. And as I mentioned, as more genetics are found, this will likely have a larger role in genetic testing in the future. And so I feel like in someone who were suspicious of a diagnosis of either Ehlers-Danlos, connective tissue disorder, or Marfan syndrome, I find it very helpful to refer to genetics here, specifically because the recommendations based on physical exam and other ways to diagnose, specifically with Marfan's and Ehlers-Danlos, are changing constantly, it seems like. So in terms of Marfan, there was the Ghent criteria were recently updated to try to increase the specificity. And so part of that is the echocardiogram and looking for aortic root dilation. So it is obviously important to come to cardiology. But I often wonder if it's important or helpful to go to genetics first and have a diagnosis either for Marfan's or unlikely to be Marfan's. With that said, most of the time they will refer to cardiology as both for the Ghent criteria and to help diagnose Ehlers-Danlos, the presence or absence of aortic valve disease or aortopathy is part of their diagnostic criteria. If a child is found to have Marfan syndrome, Loeys-Dietz, Ehlers-Danlos, we will do yearly echocardiograms. And then also, what we often see is just very flexible children who seem to have connective tissue disorders but don't quite fit the criteria we currently have for Marfan's or Ehlers-Danlos, and sometimes they do have dilated aortic roots, and those children will also follow yearly. And these are the cohort that will likely at one point be diagnosed with a currently unknown genetic mutation and genetic diagnosis. And so this is kind of a cautionary tale about why taking as detailed a history as possible is very important for stratification of certain different positivities that we'll find on the family history. So the example is if you're asking and you ask is there anyone with an enlarged heart, and someone says, yes, my grandfather had a dilated heart, he got it when he was older in his life, in his mid-60s, that is unlikely to be a heritable cause or a mutation that's causing the dilated cardiomyopathy. Most likely it's caused by an ischemic cardiomyopathy, as this is the most common type of dilated cardiomyopathy. And so this is obviously secondary to ischemic causes due to coronary artery disease and myocardial infarction, and again is not caused by a mutation in the sarcomere. So just doing a blanket, does anyone have an enlarged heart, and if someone says yes, then refer to cardiology, would not be of much utility. It really is important of what was surrounding the diagnosis, what was the age of diagnosis, to help us kind of stratify that patient and determine, does it sound like it's an inherited mutation, or does this sound more consistent with secondary causes from ischemia and coronary artery disease? If it is thought or found to be secondary to coronary artery disease, that would be in its early less than 50, then that would be something that we would check the lipids for and if abnormalities and refer to our preventative cardiologist. So kind of getting to the crux of the talk. So when to refer? So really it's for any individual that has an affected first degree or sometimes second degree relative with the potential for an inherited cardiovascular malformation. And that really is dependent on kind of your suspicions, or if the family members are very clear about the diagnosis and we know that it's a inherited form. If you're ever unsure and it sounds like it could be inherited, you can always err on the side of caution and refer to cardiology based on the family history. But oftentimes this can be, figured out either by just asking a few more pointed questions or potentially obtaining genetics or the autopsy of that individual of concern. Specifically, though, in the situations with autosomal dominant inheritance pattern of the three I listed, and also of individuals with at increased risk of congenital heart disease, I would refer all first-degree relatives. And just to refresh, these are for hypertrophic cardiomyopathy, long QT syndrome, people with left ventricular outflow tract obstruction, such as hypoplastic left heart or bicuspid aortic valve, and then people with diagnosed Ehlers-Danlos or Marfan syndrome with phenotypic concern of the child. So in summary, the family history is very important, and it can really help us stratify our individuals and our families. And I think as more is learned about genetics and the genetic basis for pediatric cardiovascular disease, I feel like the family history will have a central role in our management of our patients. And I feel like primary care providers are in a perfect position to kind of play out what our goals are in treating the children, which is really primary prevention and early intervention. So thank you so much for listening. And if you have any questions, I think you dial *6 to unmute yourself. Thanks again.